Whether you're fighting, healing, caregiving, treating cancer, or simply searching for hope, this space is for you. Welcome to FU Cancer, where meaningful conversations meet powerful community. My name is Juliette Jorgensen. I'm your host, a registered dietitian and cancer advocate, and together we're turning challenges into connection. Check out our platform on the web at fucancer.health. Welcome, Dr. Neil Jairath.
Thanks for having me.
Of course, thank you for being here. Dr. Neil Jairath is a dermatologic surgeon and Mohs surgery fellow at Indiana University, where he specializes in removing skin cancers and helping patients heal with the best possible outcomes. He completed his dermatology training at NYU, where he served as chief resident and earned his MD from the University of Michigan. Neil's research focuses on using artificial intelligence to improve how skin cancers are diagnosed, staged, and treated. He has published over 50 papers in journals including JAMA, Dermatology, and Lancet Oncology, with a passion for making sure advances in technology translate into better care for real patients. Outside the operating room, Neil is a physician entrepreneur on a mission to keep patients moving when it matters most. He's the founder and CMO of KinetiTec, a health technology company building an intelligent acute and post-acute care mobility platform designed to combat the epidemic of in-hospital immobility. KinetiTec's device helps patients stay active from their hospital beds, opening the black box of inpatient mobility and giving care teams real data to guide recovery. Neil believes that the future of cancer care and medical care as a whole depends not just on better treatments, but on better tools, better access, and a commitment to meeting patients where they are. Neil, it's an honor to have you here with us today. Thank you for joining us.
Wow, thanks. That's great. It makes me sound so cool.
You are cool. So let's kick it off with some questions. We've learned that you're a dermatologic surgeon specializing in skin cancer, but you've also stepped into the world of health technology and mobility. Can you share what inspired you to step into solving inpatient immobility?
Yeah. This is maybe going to sound a little funny, but it was in my at the end of my medical school and the beginning of my intern year. But my wife, Shreya, actually brought the problem to me. She's a nurse, and one day she told me I needed to build something for bedbound patients in the hospital. I took that pretty seriously, so I started paying attention on my own rounds. And once I started looking, I couldn't really unsee it. Almost every patient I rounded on, as you know, maybe I'm sure you've seen in the hospital too, was in bed, not because they couldn't get up, not because anyone had decided they shouldn't, but because the whole system around them was sort of built in a way that made staying in bed the path of least resistance.
Yeah.
The other thing I noticed was that a lot of the patients I was discharging weren't actually going home. You know, the patient gets medically better and then they need to recover somewhere else. And, that could be a skilled nursing facility, an inpatient rehab, sometimes worse. I can't tell you the number of patients I've taken care of that walked into the hospital on their own 2 feet for what was supposed to be a super straightforward admission. And a week later, they couldn't stand up without two people helping them. Then they get caught in this cycle. They go to a facility, they get weaker, they get readmitted, they get weaker still. It's this downward spiral that's really hard to pull out of. So when I looked at why this was happening, the barriers were sort of everywhere. Fall liability, bed rest orders that nobody remembers to discontinue, IV lines, catheters, bed alarms that all send the same message, which is stay where you are. So staffing realities that made it almost impossible to walk patients consistently are part of that too. The solutions that we saw didn't really meet patients where they were, and they didn't really make life any easier for the staff. And there was no really good way to rehabilitate, or what we like to say prehabilitate patients during the stay before things got worse. And that's kind of the gap that I wanted to help close.
Yeah, super important. And I think it is, as a clinician, I've noticed that in the hospital but I never really question it. Why aren't we questioning it? These patients do come in walking on 2 feet and then leaving kind of wheelchair bound oftentimes. So, yeah, super important. And you kind of alluded to it in that, but can you explain a little further for our listeners how quickly muscle loss and weakness can happen during a hospital stay and from your perspective, why is mobility such a critical part of recovery, especially for patients undergoing cancer treatment or surgery?
Yeah, it's a really good question. I think it's one that's like very often overlooked because it happens a lot faster than people realize, especially in older patients, and faster than most clinicians really talk about. So, healthy older adults lose meaningful muscle mass within the first couple of days to a week of bed rest. They can lose up to 2% of muscle mass a day if they're staying sedentary in their bed. And in the ICU, critically ill patients can lose, up to 3% in the early phase of their stay. And that's per day, not a
Yeah.
typo. For a cancer patient or a surgical patient, those stakes compound. You're already dealing with a body that's under stress from the disease, from treatment, from the procedure itself. If you add immobility on top of that, then you're not just losing muscle, you're losing, the physiologic reserve that a patient needs to tolerate the next round of chemo or immunotherapy, to recover from the next operation or to make it through rehab and actually go home. And the other piece I think people really miss is that strength loss isn't really symmetric with strength gain.
Mm.
A week in bed can take months to rebuild. So it's really important to get ahead of it. When we tell someone, just rest, you've been through a lot, we're often sort of handing them a problem that outlasts the original reason they were admitted.
Yeah. Yeah, that's so true. And I think, we often think rest equals healing, but in the hospital setting, as you just explained, we can understand that's not always true. What are some more medical complications that you've seen, with patients when they remain inactive for too long?
Yeah, I mean, I think there are two ways to look at it. There's like the direct list of complications, and then there's a whole bunch of indirect ones that are sort of tied peripherally to immobility. But the visible ones are pressure injuries, clots, pneumonia from not taking deep breaths, falls. Actually, when patients finally try to get up after days in bed, delirium is a big one that contributes to increased length of stay, and a whole bunch of other medical complications, and they're very serious. Delirium actually gets worse the longer someone is immobile, and that has its own downstream effects on cognition that can persist for months after discharge. Insulin resistance starts to climb within days for diabetic patients, which is why blood glucose can get harder to control. Patients who could climb a flight of stairs at home are short of breath walking to the bathroom by discharge, especially in the cardiovascular population. And they're all kind of cumulative. A patient doesn't really just get one of them when they're immobile. They get a little bit of each, and that kind of smattering combines together to determine whether they end up going home or not, or whether they end up in this vicious cycle of readmissions and deconditioning.
Right. Yeah. And so you founded something that is addressing this, at the root cause. You founded KinetiTec to address this issue. Can you walk us through how your bedside cycling platform works and what makes it different from traditional physical therapy or rehabilitation tools?
Yeah, definitely. So KinetiTec, we have renamed our device to the KinetiTec Spark, is an in-bed mobility intelligence system. So it's got two parts, hardware and software. The hardware is a recumbent cycling device, like you alluded to, that fits at the foot of a standard hospital bed and lets a patient pedal from the supine or semi-recumbent position. They don't have to get up, they don't have to transfer, they don't need a therapist physically present to start a session. And that matters because the biggest barrier to in-hospital movement is really patient willingness all the time. It's logistics. Getting someone safely out of bed takes staff, equipment, and time. And most units don't really have a surplus of those. So what makes the Spark different from a pedal exerciser or a piece of rehab equipment is the data layer. So every session captures objective metrics like resistance, cadence, strength, duration, effort over time, and that information can flow to the care team in a structured way. So instead of a nurse charting patient ambulated in hallway or tolerated PT well, you have actual numbers that show what a patient did, when they did it, and how it's trending across their stay. Unlike some of the pedal exercisers you can bring to the side of a bed, it's not 80 pounds, it's under 12. It
Mm.
doesn't have a plug-in, no outlet needed, so there's no hazards with keeping it in the hospital. It actually recharges with use, and it's very compact, the size of a cereal box, so easy to fit at the end of a bed.
That's incredible. I think every hospital needs these. That's amazing. Wow. So you kind of explained it already, but having like how does having this tangible, measurable mobility data change and inform the way that clinicians can make decisions about a patient's recovery?
This is the question I'm super passionate about. Right now, mobility is one of the only things in the hospital that really isn't measured objectively, which is
Mm.
to me crazy. You know, we have continuous monitoring for heart rhythm, for oxygen, for blood pressure. We have lab values for everything else. For mobility, which has been shown in so many trials to be so impactful on a patient's overall well-being in the hospital and so predictive of so many outcomes, we usually have a nurse's note that says patient up to chair or ambulated with assistance, and that might be written hours after the fact based on memory or patient report. When you put real numbers in front of a clinician, the conversation changes. You know, a physical therapist can see whether a patient actually moved between sessions. A physician rounding in the morning can see whether yesterday's mobility plan happened. A discharge planner can look at a trend over the last 3 days and have an informed conversation about whether home is realistic or whether this patient needs a higher level of care. And the other thing that data does, which I think is really important, is makes, you know, what's currently invisible visible to the patient and to the family. So when you can show somebody a chart of their own activity going up over the course of their stay, that's pretty motivating in a way that, you know, you're doing great, keep it up, isn't necessarily. And when activity isn't going up, that's a signal, right? To the team, to the family, to the patient that something needs to change before you hit that discharge button, you know, not afterwards.
Yeah, absolutely. I can hear your passion in your voice, and I think it's just incredible. So thank you for what you're doing. It's really wonderful. So for patients that may be listening or caregivers who may be, facing a hospitalization or cancer treatment, what are some simple ways that they can advocate for movement, and maintaining strength during recovery if they, don't have access to Spark KinetiTec?
Yeah, I mean, I think there are a lot of things, and I think one thing that I've really noticed and been encouraged by in the hospital is how motivated the caregivers of cancer patients and really all patients are in the hospital. So I think there's a lot, you know, they can do. You know, first just ask the question, like on rounds on day one, ask the team what the mobility plan is, right? Not is it okay if I get up, but what are we doing today to keep me or my family member moving? And that single question changes the default from bed rest to activity. You know, the care team knows you're aware. The care team might feel like this patient is motivated to move, and it's kind of a signal for both sides. And second, if you're a family member, you have permission to help. A lot of the time, patients move more when their family's in the room. You know, you can walk a lap of the unit together. You know, grab the nurse if they're available. Sit up in the chair for meals instead of eating in bed. Those small things can sort of compound over a week, and I think it's important to push back a little bit on the language of rest. You know, when someone says you need a rest and let your body heal, that's great for the first day or two, but then it kind of stops being true. So after that, rest kind of becomes its own problem. And it's okay to ask, you know, like, what can I do safely today? Or, you know, what should I be able to tolerate and get a real answer. And if you're the patient, you can be the one driving it, right? I mean, the most successful recoveries I've seen are the ones where the patient walks in already understanding that getting better isn't really something that just happens to them, but it's
Mhm.
something that they can actively participate in.
That's so true. I love how you, empower patients and empower caregivers to speak up and to question things and ask, hey, when can we take a lap around, or is this okay? Can we move today? How can we move today? I think that is really valuable and a great tip. Thank you. So, transitioning back to what your clinical practice looks like, your research focuses on using artificial intelligence to improve how skin cancers are diagnosed and treated. Where do you see AI making the biggest impact for cancer patients in the next 5 to 10 years?
Yeah, awesome question. I mean, the field is moving so incredibly fast that it's almost like it almost feels wrong to say, but it's a lot of way through a guess. I think probably the splashy stuff isn't really where the biggest impact will be. I mean, I think everyone wants to talk about AI reading scans or AI diagnosing cancer from photos. Yeah, that's real work that's been done, but I don't think it's going to change outcomes for patients that much in the next decade. I think the places where AI will actually move the needle are a little more subtle. The first, I think, is access, right? Like a huge percentage of skin cancers are diagnosed late because patients in rural areas or Medicaid can't get to dermatologists within a reasonable time frame. I think dermatology in some ways is kind of like vaccines, where we've gotten so good at treating skin cancers with such high cure rates that people forget, what skin cancers can do if you don't treat them and don't get early access to them. But we see those things. So I think, that'll be a huge difference maker. And the second, I think, is reducing variation in care. Two patients with the same cancer can get very different treatment depending on where they live and who they see. So really being able to deliver the highest quality of care to underserved populations or people that may not have access to, the institutions with the best clinical trials, I think will be important. Without, of course, replacing physician judgment, I think you can kind of narrow the gap. And the third, and I think maybe the most immediate, is kind of what we've been talking about. AI applied to operational problems. In hospital mobility, maybe one, medication management, care coordination. There's so much infrastructure to how care gets delivered that's so like incredibly complicated in today's health system that simplifying even a step of that process every year would lead to such outsized benefits over the next decade. So I think that's probably the highest yield impact.
Definitely. I completely agree. And those are all great ideas and exciting things to look forward to. So thank you for that insight. And then one more question for you before we finish today. If you could wave a magic wand and change what hospital recovery looks like for this patient population, what exactly would you change?
Yeah, I alluded to it a little bit earlier before, but I'd make mobility a vital sign.
Mm,
I think, right now we measure heart rate, blood pressure, temperature, respiratory rate, oxygen saturation, every shift on every patient in every hospital. Those five numbers determine such an enormous amount of what we do. If a patient's blood pressure drops, the whole team knows within minutes, right? With good reason. And if a patient oxygen drops, the alarms go off, people come running. But if a patient hasn't moved in 3 days, nobody has any idea. There's no number on the chart. There's no alarm. There's no trend line.
mm,
The thing that, more than almost anything else predicts whether that patient goes home or to a facility, we don't really measure it. So if I could change one thing, that would be it. Make mobility the sixth vital sign. Put a number on the chart every shift. Give the team a trend. Treat it with a similar seriousness to what we treat the other five. And I think, what's really important about that is once you measure something, you start managing it. And I think that's where the importance of that measurement is going to lie.
absolutely. Yeah, I agree. Let's add it. I wish we could. Yeah. Well, thank you so much, Dr. Jairath. You have just such incredible wisdom and insight, and I love everything you're doing. I know that our listeners will enjoy listening to this episode. So thank you for taking the time to be with us here.
Awesome. Well, yeah, thank you for what you're doing. I think it's such an awesome mission, and I am just excited to be a small part of it.
Oh, thank you. The conversation doesn't end here. Join our community today at fucancer.health for trusted education, real community, and resources. We are here for you every step of the way.